Good afternoon, everybody. We're very excited to have Dr. Zoe Muller here. Dr. Muller is a faculty member with the Florida Caribbean AETC and is a clinical assistant professor in the Division of Infectious Diseases and Global Medicine at the University of Florida in Gainesville. She practices general infectious disease, taking care of HIV-infected patients at SHANS at the University of Florida. Dr. Muller's specific interests include HIV provider education and the prevention and management of HIV infection in adults. As a faculty member of the Florida Caribbean AETC, she is currently involved in lecturing on opportunistic infections in HIV patients, as well as editing the Opportunistic Infection in HIV resource. Dr. Muller is a board certified in both internal medicine and infectious disease. We're very happy to have her today, and Dr. Muller, I'm going to turn it over to you to start your presentation.
Great, thank you. Thank you very much. I want to thank you all for joining me today. As mentioned, I'm Dr. Muller, and I'll be talking to you about, over the next hour, about HIV and the management of opportunistic infections. So I do not have any financial relationships with commercial entities to disclose, and I will not be discussing any off-label use or any investigational products during this program. So over the next hour, I hope to accomplish a series of objectives. I'd like us to be able to define and recognize the most common opportunistic infections. I'd like to touch on the key functions of a CD4 cell. I'd like us to be able to recognize the differences between primary and secondary prophylaxis, as well as to identify risky behaviors that can increase the risk for opportunistic infections. And finally, towards the end, I'd just like to talk quickly about the routine vaccination schedules and contraindications to certain vaccines. So to start off with, what is an opportunistic infection? And throughout the rest of the presentation, you'll see that I abbreviate it as OI. So an OI is basically an infection by a microorganism that normally does not cause disease, but becomes pathogenic when the body's immune system is impaired or unable to fight off infection. And I think for us to better understand this, we really need to know more about the relationship between the HIV virus and the CD4 cell. So the CD4 cell is also known as a T cell or a T helper cell, and it's basically a type of white blood cell that really plays an important role in helping the body fight off infections, whether that be from bacteria, funguses, or viruses. And you can see on this diagram here that the HIV really has an affinity for this specific cell. It's able to attach itself to the membrane, to get inside the cell, make copies of itself, and then it buds off the cell, being released into the bloodstream. And it's at the point where it releases itself from the cell that the CD4 cell dies. And that's why in HIV patients who are not treated, over time their CD4 counts begin to drop. And basically the body loses the ability to fight off certain infections. And that's when you begin to see these opportunistic infections. So as mentioned, a CD4 cell is a type of white blood cell. Healthy individuals who do not have HIV typically average between 500 to 1,500. CD4 counts are important because it guides the management of HIV. It lets us know how urgent it is for us to start treatment, as well as what prophylaxis we need to give patients for these OIs. And we're going to see that it basically determines our OI risk, because when CD4 counts drop below certain levels, that's when we really begin to see specific opportunistic infections. So some of the major OIs to know, TB is going to be right at the top here. That's because in HIV populations, TB is really the most common OI that we're going to see. The rest on the list here, you can see pneumocystis pneumonia, abbreviated PJP. We have Mycobacterium avium complex, otherwise known as MAC. Quite a few enteric organisms. When I mean enteric, I mean gastrointestinal pathogens, basically things causing things like diarrhea and fever and abdominal pain. These would include certain bacteria like Salmonella, Shigella, Campylobacter, Listeria, but also parasites like Cryptosporidium. Cryptococcus is the next one down, and this is a fungal infection, which we'll talk about later. And we also have histoplasma and coccidioidomycosis, also fungal infections, which have more of a geographical distribution. And finally, toxoplasma, which is a parasite. OIs can also be viruses, and here is a list of the most common ones. You can see cytomegalovirus, or CMV, at the top. We have herpes simplex virus, both 1 and 2, and these are typically associated with ulcerations of the oral or genital tract. We have human herpes virus 8, which is associated with Kaposi sarcoma, which we can see in HIV patients with very low CD4 counts. It's a type of cancer. Human papillomavirus, which can cause genital warts as well as certain genital cancers. And varicella zoster virus, which we commonly refer to as chickenpox. So I think this table just illustrates the major OIs, basically classification or the type of organism, as well as the predominant symptoms that we associate with it. So for TB at the top, it's a bacterial infection. We do typically think of it as causing pulmonary manifestations, but it can also disseminate. And when I talk about dissemination, I mean it can spread throughout the body. So it can go to the liver and it can go to the central nervous system to cause things like meningitis. And the next one down, MAC, is also a bacterial infection, and it too can disseminate. And it's estimated that about 40% of HIV people that have MAC actually have the disseminated form. Enteric pathogens, again, or those GI pathogens, can include things like bacteria and parasites. They typically cause diarrhea, which may be bloody or non-bloody, fever, as well as abdominal pain. Pneumocystis pneumonia is a fungal infection that we typically see as causing pneumonia. Cryptococcus below is also a fungal infection that predominantly causes central nervous system issues like meningitis, but it can also disseminate and cause pneumonia as well. Histoplasma is also a fungal infection. We typically associate it with exposures from Ohio and the Ohio River Valley. Typically causes disseminated infections that can cause skin changes, can cause fevers, lung manifestations, as well as meningitis. And the same goes for coccidiomycosis, which we typically see more out west, around California and Arizona. It's also a fungal infection. CMV is a virus, as we spoke about before, and this typically in AIDS patients causes CNS manifestations, be it meningitis or things like retinitis. And it too can disseminate. It can present as a GI manifestation as well and cause things like colitis and diarrhea. And finally, toxoplasma is a parasite, and we're going to talk about that a bit later, and it primarily causes CNS manifestations as well, either meningitis or an encephalopathy. So at what CD4 count do we start to see specific OIs? So you can see here in this table that when the CD4 count drops below 200, we begin to see things like PJP. When it drops below 100, you can expect to see things like toxoplasma, CMV, or cryptococcus. And when it drops even further below 50, you can begin to see things like MAC. So OIs and HIV. Opportunistic infections can be the very first presentation of someone having HIV. They can also be associated with immune reconstitution inflammatory syndrome, abbreviated IRIS, and we'll talk about that more on the next slide. The next point here about highly active antiretroviral therapy, it's important to know that when we treat certain OIs, we also have to be careful of drug-drug interactions. So certain specific drugs that we treat OIs can interact with the drugs that we treat the HIV with. OIs can be a big cause of morbidity and mortality, and they're preventable, so to some extent, in the sense that we can give patients antiretroviral therapy to bring up their CD4 counts, we can give them primary or secondary prophylaxis to protect against these OIs, and we can also talk to patients about the risk factors for obtaining these OIs so that they may know to avoid certain things to minimize their risks. So what is IRIS? Again, so IRIS stands for Immune Reconstitution Inflammatory Syndrome. It's basically an inflammatory disease that occurs in response to a specific opportunistic pathogen, typically happening within weeks or months after starting antiretroviral therapy. It can either present as an exacerbation of a partially treated or recently treated OI, or as an inflammatory response to a previously undiagnosed opportunistic infection. And it's basically caused by the body's enhanced and dysregulated immune response to these various antigens. So essentially, as we treat HIV, what happens is the body's immune system recovers, it begins to wake up, and it takes notice of latent infections that may have already been there, or new infections that they obtain that the body wasn't able to recognize before, and it basically has an exaggerated response in dealing with these infections. So who is at risk for IRIS? Greater risk when you start antiretroviral therapy at a high viral load and a low CD4 count. It can be very difficult to identify. There's no specific laboratory test to identify IRIS, and it's basically a clinical diagnosis. So you're looking at a constellation of symptoms that may have a temporal association to when ART was started. The severity can vary really from mild to life-threatening, and so it's always important to keep a very high index of suspicion if you suspect it, and to make sure that you refer patients to their HIV care providers so that they can be further investigated. The management of IRIS typically involves treatment of the OI, as well as continuing ART therapy, and sometimes anti-inflammatory use is also considered. Prophylaxis for these opportunistic infections, they can be primary or secondary. It's important to know the difference between the two before we get into them. So primary prophylaxis is basically prevention of the first episode of an infection, and when we stop and start it is based on the CD4 count. Secondary prophylaxis refers to prevention of a recurrence of infection. And we're basically going to see that not all OIs do we prophylax for. So certain things like Candida infections or Cryptococcus or CMV, they don't get prophylaxis for those. But for a majority of ones, they do. And I'll refer you to this website at aidsinfo.nih.gov. And this website basically has a lot of information about the guidelines for the prevention and treatment of opportunistic infections. It's very easy to use. It goes into great detail about what drugs are recommended, what to do if patients have allergies to the mainline drugs, and it will give you lots of information on alternative treatments. So primary prophylaxis. Let's start with PJP. So the indication to start primary prophylaxis, and again, it's to prevent the first occurrence of disease. We typically start at a CD4 count of less than 200, or equivalently at a CD4 percentage of less than 14. Another indication would be if a patient has oral candidiasis, which is essentially thrush, and usually we associate thrush with patients having a low CD4 count below 200. Preferred drug for prophylaxis would be Bactrim, given as a double strength, that's DS, or a single strength, that's SS, 1 tablet daily. For toxoplasmosis, we typically start primary prophylaxis when the CD4 count is less than 100 and they have a positive Toxoplasma IgG antibody. Again, preferred drug is Bactrim, 1 tablet a day. So you can see that for PJP and toxoplasmosis, we actually use the same form of prophylaxis, which is Bactrim. For MAC, we typically start prophylaxis when the CD4 count is less than 50 and there's no evidence of active infection. The preferred drug for this would be azithromycin, and it's given as 1,200 milligrams oral once a week, or clarithromycin 500 milligrams orally twice a day. Alternatively, we could give azithromycin, a 600 milligram tablet orally 2 times a week. So when do we stop this primary prophylaxis? For PCP, we typically stop when the CD4 count is above 200 for more than 3 months, and it can be restarted again when the CD4 count drops to below that 200 level. For toxoplasmosis, it's the same thing. Again, when the CD4 count is above 200 for 3 months, we can stop, and then restart it again when the CD4 count begins to drop. For MAC, the last one here, we prophylax for a CD4 count of 300 for more than 3 months, and then similarly restarted when the CD4 count drops to below 50. So secondary prophylaxis is ensuring that the patients have already had their infection, and we want to make sure they don't have it again. So for PCP, typically when we treat acute infection of PCP, or PJP rather, we usually treat for 3 weeks with a high-dose Bactrim. Once the initial episode is treated, we transition patients to Bactrim, either a 1-tablet double-strength or single-strength daily, and we continue this until their CD4 count is more than 200 for more than 3 months. For toxoplasmosis, what we do is we typically treat the acute infection again, and typically infection treatment is usually 6 weeks. And after that, we transition patients to pyrimethamine, either 25 to 50 milligrams daily, or sulfadiazine, 2,000 to 4,000 milligrams once daily, in addition to leucovorin, 10 to 25 milligrams daily. This is basically then continued until the CD4 count rises to more than 200 for more than 6 months. So for secondary prophylaxis for MAC, the last one here, so the prophylaxis is actually essentially the same as the treatment regimen. So patients typically get treated for MAC for more than 12 months, and then they go on to suppressive therapy. And this is typically clarithromycin, either 500 milligrams PO BID, or ethambutol 15 milligrams kg PO once a day. Alternatively, if they can't take clarithromycin, we can give azithromycin 500 to 600 milligrams daily, in addition to ethambutol 15 milligrams per kg orally once daily. And as we said, after the initial treatment, this suppressive regimen continues until their CD4 count is more than 100 for more than 6 months. So we're going to touch a bit for the next section about OIs and specific exposures. So as we said, there are certain things that patients can do to minimize the risks of obtaining these OIs. And it's important to know about this so that we can advise them accordingly. So some of the major exposures we'll focus on include sexual exposures, exposures from IV drug abuse, environmental exposures, as well as those from other individuals, animal-related exposures, whether they be from a work situation or from domesticated or wild animals, food and water, and finally we'll finish up by talking about travel exposures. So sexual exposures, you have a whole list here, and I'll start with the hepatitis viruses. So hepatitis A virus is a virus that is typically obtained through food and water. However, there is a risk of obtaining hepatitis A through sexual activity. And the reason for this is that hepatitis A is basically a fecal-oral transmission spread. And so certain populations that may practice oral anal intercourse, typically perhaps males who have sex with males or MSM populations, they may be at specific risk for this, so it's important to realize that so you can inform them about appropriate vaccination. Similarly, hepatitis B is another virus that we do have a vaccine for. There is a high risk with sexual activity. Hepatitis C has a small risk through sexual exposure. It's primarily a risk through IV drug abuse. This is a virus that we can treat, but there is no vaccine for it as of now. Human papillomavirus, which we said causes these genital warts, there are vaccinations for these, which we'll talk about towards the end of the presentation. Cytomegalovirus is sexually transmitted, as well as herpes simplex virus. Certain STDs like syphilis, chlamydia, gonorrhea, they can all be transmitted easily. And then again, the enteric organisms, such as Shigella, Salmonella, and certain parasites like Cryptosporidium. So prevention. Mainstay of prevention is going to be condoms. So condoms can be used for oral, vaginal, or anal intercourse. We have specific condoms for males as well as females, and they come in two forms, either as a latex or a polyurethane. And they're about 80 to 97% effective in preventing HIV as well as other sexually transmitted diseases. Latex dental dams is another form of condom. It's more of an oral type of condom that can be used for oral intercourse. It's important to make sure that patients are using condoms correctly, and we'll touch upon that on the next slide. And patients should also avoid sexual activity when their partner has active herpetic lesions, and that's to prevent transmission of the HSV. Annual screening is recommended at least once yearly. However, if patients are at very high risk, they should be monitored more frequently. And it's important to remember that often the presence of one sexually transmitted disease may signal the presence of another. So instructions on standard condom use. So a new latex or polyurethane condom should be used every time. It should be undamaged, and patients should really check the expiration date before use. They should be carefully handled. Women especially may want to make sure their nails are trimmed in order to risk tearing. When applying the condom roll should face out, and the tip of the condom should really be pinched when applying it to the top of the erect penis. Lubricant is actually recommended to be used as well on the inside of the condom. Too much lubricant may cause the condom to slip off, but about a drop or so may reduce the risk of friction and microtrauma and prevent the condom from actually rupturing. So what type of lubricants do we have? We have water-based lubricants that should be used with latex condoms, as well as oil-based lubricants that we can use with the polyurethane condoms. Certain things to tell patients to avoid would be non-oxynol 9 or an N9 spermicide, and this has actually been shown to increase the risk of HIV transmission during vaginal or anal intercourse. And the reason for this is that the spermicide is very damaging and abrasive to vaginal and anal mucosa, and that actually creates breaks in the mucosa, and it can serve as ports of entries for the virus to enter. Patients should avoid using two condoms at the same time. Again, the use of two condoms can rub against each other, create friction, and can cause the condom to rupture. Finally, female condoms. So female condoms are a bit more expensive than male condoms. They can be used during vaginal and anal intercourse. Again, you have the latex and polyurethane types. Female condoms can have several benefits despite being more expensive. And just going quickly back to the application, what it basically, how it works is it's actually a pouch that has a closed ring at one end, and that pouch gets inserted into the body, and it's open at the other end. And so female condoms are something that can provide tremendous benefit to patients, but it's not very well known. Next, talking about injection drug use, another exposure that was on our list. So we can think about hepatitis C virus. And hepatitis C is probably one of the most common ones that's transmissible. And as I mentioned before, this is something that we can treat, but there is no vaccination for it. Other things to consider in terms of transmission would be bacterial infections. Specifically, we think about Staphylococcus aureus, and more specifically, methicillin-resistant Staphylococcus aureus. Bacterial infections can cause issues with skin, causing cellulitis, can also get into the bloodstream, causing things like bacteremia. It can lodge on heart valves, causing endocarditis, as well as affect the bones to cause osteomyelitis. Certain drugs can be contaminated with other products, so that's always something to watch out for. For example, black tar heroin, there's a risk of contamination with Clostridium species. And in general, drug use can increase risky behavior. Patients may feel more promiscuous, less inhibited, and have a greater tendency to practice unsafe sex. So prevention, how can we help patients with their habits? We can refer them to treatment programs that we may have in the area. We can also immunize against things that we're able to immunize for, such as hepatitis A and hepatitis B. We can discuss ways for patients to avoid sharing needles and other equipment. And we can also advise them on the proper way to clean equipment, as well as certain programs like needle exchange programs that may be available in certain states. Just wanted to bring your attention to the idea of dead space. And dead space basically refers to the amount of fluid or blood that would be in a syringe after the plunger is completely depressed. And you can see on the picture on the far left here that once the plunger is depressed, you still have quite a bit of residual blood, be it in the tip of the needle itself, the hub, as well as in the syringe. Contrast that to the low dead space syringe, which is a specially formulated type of syringe, on the right, where once the plunger is depressed, basically the blood just remains in the tip of the needle. And so obviously the less blood that you have remaining, i.e. the less dead space, the less likely you'll be to transmit the remaining blood and cause infection. And it's estimated that a low dead space syringe may have about 2 microliters of blood in there. Compare that to a high dead space syringe, which may have up to 84 microliters. So something to talk to patients about. Certain methods for cleaning. So this is from the CDC website. It's called the 2x2x2 method, and it's a mechanism whereby patients can clean out their syringes. So it involves ingesting cold water, sterile water, into the syringe and flushing it twice, followed next by bleach into the syringe and shaking it for about 3 to 5 minutes before flushing it, and then repeating this step twice, and then going back to step 1 again. Other things that patients can do would be to boil their needles and their equipment for about 15 to 20 minutes, or even to use bleach to soak their paraphernalia. Other exposures that we may have are environmental exposures, and we'll talk about Toxoplasma gondii, which may be found in soil or soil contaminated by feces from animals, Cryptosporidium, which is a parasite, Coccidioides, again, that fungal infection typically associated with more of the western states, Histoplasma capsulatum, another fungal infection around the Ohio River area, also associated with soil contamination or feces from birds or bats. And finally, Cryptococcus neoformans, which is again a fungal infection that we can see in soil, in decaying wood, but also it is found in pigeon droppings. And Aspergillus, another fungal infection that can be associated with soil, as well as funguses from old buildings. So how do we come across these infections in our daily lives? Certain organisms are ubiquitous, so they're all around us, things like Candida, things like MAC, Cryptococcus, and PJP. As I mentioned, depending on where you live, you could have a greater risk of exposure to things like Histoplasma and Coccidioides. They could be work-related, so patients that are involved in renovating old buildings, let's say, could be at a greater risk. Or if they're involved in construction that involves churning up soil that may have feces from certain birds, they could be at risk as well. Finally, hobbies of patients. They could be gardening, so patients that will come into contact with soil quite a bit. As I said, they have a risk of acquiring Toxoplasma, Cryptococcus, or Histoplasma just because these organisms are found in the soil. So how do we help patients prevent exposures to these? So we recommend that they wash their hands. We recommend that they wear protective gear if they're going to be gardening, wearing gloves, for example, or masks if they're going to be working in old buildings or doing construction. Patients that live in an area where histoplasma has a high incidence, like in the Ohio area, and if their CD4 count is less than 150, should take special precautions. So it's recommended that they avoid cleaning, remodeling, or demolishing old buildings, and that they avoid disturbing soil beneath any bird roosting sites, and that they stay away from cave exploration or spelunking. And again, that's because histoplasma can be found in the droppings of certain bats. And they should also, as a general rule, just avoid contact with bird or bat droppings. Next, exposures can occur from other individuals, be it by daily activities or from places of employment. And it's important to realize when we talk about employment, it's not only thinking about staff, but also others like volunteers. So individuals working in healthcare facilities, correctional institutions like prisons, homeless shelters, these are all areas where patients can pick up opportunistic infections. And TB is always the biggest one that we think about, specifically in relation to prisons and homeless shelters. Another thing to consider is childcare facilities, so providers of these facilities or parents with children in daycare. Children tend to get frequent infections and they can bring these infections home. So things like CMV, Cryptosporidium, hepatitis A, giardiasis, which is a GI infection, as well as flu. Getting back to the point on TB, just because TB is so important and such a global phenomenon, especially as a big risk for these HIV patients. So the risk in someone who has HIV of acquiring TB is about 5 to 10% per year. Contrast to someone who does not have HIV, the risk of TB is about 5% over their lifetime. Patients are typically screened for latent or inactive TB, and that involves placement of a PPD. And a positive test, once the induration is measured, is usually greater than or equal to 5 millimeters. Of course, it's important then that we outrule active disease, and we typically doing this by having a really good symptom review and sending patients for a chest x-ray. It's important to remember, though, that if patients have had a significant TB exposure, be it that they've come into very close contact with someone who's had active TB, it's important to treat for latent TB regardless of what their PPD result was. And that is typically with the use of isoniazid, abbreviated INH, which is given for 9 months. Another point to consider is that when we treat TB, specifically the active disease, where we may use about 3 or 4 drugs, certain drugs, specifically rifampin, can actually interact with the HIV medication that we use. So it's important to realize that, and sometimes we switch out the rifampin to something else, like rifabutin, for example, or we may adjust the dose of certain antiretroviral medications. BCG is a vaccine. We don't typically hear about it in the States so much, but definitely overseas in Asia, something that's given to patients, but it's actually contraindicated in HIV patients just because it is a live vaccine. Finally, getting to animal exposures that some patients have many questions on because lots of our patients may have pets. So toxoplasma is a big one. As we said, it is a parasitic infection, same with cryptosporidium. Certain enteric infections we can get from our animals, like Salmonella, Campylobacter. Other bacterial infections we can get, like Bartonella, Brucella, Cryptococcus, and Mycobacterium avium and marinarum. We're going to touch about some of the more common ones in the next slides. So how do we get these exposures? So they could be through our occupation. So veterinarians, people working in pet stores and farms and slaughterhouses, they can come into contact with infected animals. So it's important that they take precautions. They should avoid being licked, bitten, or scratched by these animals. Also, they should avoid the fleas from these animals as well as animal feces. Typically, younger farm animals or younger pets in general tend to be associated with carrying more of these diseases, so it's always wise to stay away from very young animals, specifically animals with diarrhea. So let's talk about pet cats. So cats, we all hear about we've heard about toxoplasma before. So how do cats get toxoplasma? So basically, when cats are allowed outside, they're allowed to hunt. They can eat, let's say, birds or small mice that may be contaminated with this parasite. Once the cat eats these animals, they themselves become contaminated, and then they shed these cysts in their feces. So in cleaning litter boxes, patients may inadvertently touch the feces and perhaps touch their mouth after, and that's a way that the parasite can get into the body. So it's important to minimize the risk that patients actually have their litter boxes cleaned on a daily basis. It's always best if someone who doesn't have HIV can clean the litter box, but if the patient has to do it themselves, they should always wear gloves and they should wash their hands right after. Therefore, in order to prevent cats from getting toxoplasma, we should recommend that they keep their cats indoors as much as possible and that these animals should not be allowed to hunt. Finally, one thing I didn't mention is that toxoplasma can also be acquired through the ingestion of raw meat, so cats should not be fed raw meat. Similarly, HIV patients should not be eating raw meat. Next on the list here is Bartonella. So this is a bacterial infection and typically associated again with cats, specifically from cats with infected fleas. To minimize exposures, patients should really avoid rough play with their animals. So avoid scratching, biting, licking, and if they do have any exposure, they should definitely wash these areas as soon as possible. Again, patients should buy cats that are more than 1 year of age, as the younger cats like kittens tend to have a greater tendency to have these infections. Next on the list here is birds. So lots of patients will have pet birds, and a variety of infections can be transmissible from these animals. So Cryptococcus being one of them. As we said, Cryptococcus is a fungus. It has a special affinity for pigeon droppings. It likes to grow in those. So again, if patients are outside, very near pigeons, there's a real risk that they can inhale these spores. Mycobacterium avium, another bacteria that can be obtained from birds, be it from wild birds or from domesticated birds. Chlamydia psittaci is another bacterial infection that we often refer to as parrot fever that patients can get from their parrots or their cockatiels. And again, it's through coming into contact with their feces or from any nasal discharge. And it typically presents as a pneumonia, but it can also disseminate throughout the body. And finally, histoplasma, we mentioned before, typically associated with bird droppings. So as a general rule, patients should avoid bird droppings and soil beneath bird roosting sites. We spoke about that. And they should avoid contact, again, with very young animals like chicks and ducklings, and that's primarily to prevent salmonella. Patients are going to be washing cages. They should wash their hands right after, use gloves, or again, wear masks if they're going to be working outside an environment near these birds. Last on our list is pets, so reptiles. So some patients may have turtles or snakes or lizards. There's a risk primarily of salmonella from these reptiles, as well as Mycobacterium marinarum. And Mycobacterium marinarum is a bacterial infection that typically causes skin manifestations or skin ulcerations, typically associated with water from aquariums, but also from fish. So if patients are going to be cleaning out their tanks or if they're going to be skinning fish at all, they should definitely wear gloves. Similarly, they should cover any scrapes they have or any scratches in order to reduce any potential portals of entry. And as again, for all these animals, patients should wash their hand after coming into contact with them. It's important to realize that despite these potential exposures that people can get from pets, there actually are no guidelines that HIV patients should not have pets. The pets provide tremendous benefit. It's just important that they be aware of all these risks, but they can still keep their pets with the proper precautions. Finally now, coming on to food exposures. So we spoke about toxoplasma, which we can get from ingesting raw meat. Salmonella, Shigella, Campylobacter, so these are enteric infections that can be resulted. Listeria similarly, and Cryptosporidium, which is a parasite. So how do we prevent exposures from food? Patients should avoid eating raw or undercooked food, and that's in terms of eggs, meat, seafood, which includes shellfish. They should avoid eating anything that's unpasteurized, like fruit juices or unpasteurized milk, and that's to minimize, for the fruit juices, that's to minimize the risk of Cryptosporidium. They should definitely wash their produce and avoid eating anything like raw seed sprouts. And they should cook their meat, whether it's steak or anything, until there's no traces of pink that really remain. Again, they should make sure that they're washing their cutting boards, their counters, and their utensils, and that's to avoid cross-contamination of their foods. Listeria is a bacteria that we talk about frequently. So Listeria monocytogenes, it's basically a bacteria that can cause various presentations of disease, one of them being meningitis, but also, of course, gastrointestinal symptoms like fever, abdominal pain, and diarrhea. So just as we caution pregnant women from avoiding soft cheeses, similarly HIV patients should avoid soft cheeses. Things like hard cheeses, processed cheeses, cream cheese, cottage cheese, yogurt, these are all things that are considered safe to eat. Patients should avoid eating food from delis, and the primary reason for this is because delis will contain lots of processed meats where Listeria can grow in, and another food to avoid would be something like a refrigerated smoked seafood. Water exposures, so big ones, hepatitis A, which we spoke about before, Cryptosporidium, Shigella, Campylobacter, amoeba, Giardia, Isospora, and Microsporidia. So these are all organisms that we can associate with contaminated water. So patients should really avoid drinking well, lake or river water, and that's to say they should be careful as well during certain activities like swimming or water skiing so that they don't accidentally ingest this. Also, if they're having ice in their drinks, the water should be from a trusted source. The use of submicron personal use water filters may be beneficial, but there is no data to recommend that HIV patients actually boil their water or avoid drinking any tap water. Things that are considered safe would be bottled or canned carbonated drinks, frozen and pasteurized juice concentrates, as well as alcohol. So the last on our list of exposures here is travel. And things to think about would be enteric pathogens, which we're going to talk about, such as, well, the traveler's diarrhea, exposure to malaria, yellow fever, and dengue virus. So it's important to find out where patients are traveling to and what season they're going to be traveling, as well as what type of vacation they're going to be having. So, of course, the risks, again, are for food and water from overseas. Also things like TB, so patients, for example, that are going to be in Asia, India, higher rates of TB in those places. The risk for malaria, so mosquito-transmitted illness, thinking about places in South America, as well as the Middle East, places in Africa. Rabies is essentially worldwide. It's from the bite of infected dogs, usually wild dogs. So patients that may be more hiking, let's say, in rural areas, that's something you may want to consider. So what can we advise patients? So standard, boil it, cook it, peel it, or forget it. And that's to minimize risks from food and water contamination. I'm talking about traveler's diarrhea, which is typically caused by a strain of E. coli. Patients should really bring antibiotics to take if they do have diarrhea, but there's no data to recommend that they take something prophylactically. Malaria, as we said, something to consider if they're going to certain parts of the world. Also important to remember that some of the drugs for malaria can interact with some of the HIV medication. There's always a risk of drug-drug interactions that must be checked. And of course, standard precautions like avoid being outside from dusk till dawn, or wearing repellent, or using mosquito nets. These are all things that can be recommended as well. And I think the CDC really has a great website for further information on this. Almost every country is listed there under the travel section. It can let you know what's going to be needed if you're going to a certain place, what vaccinations are recommended, and exactly what precautions you need to take. And so we'll finish up a little bit here on vaccines. Certain vaccines for traveling, we think about diphtheria, tetanus, rabies. Again, it depends on what type of trip they're doing. Hepatitis A, we discussed the importance of that. Hepatitis B, Japanese encephalitis. So this is something to perhaps consider in patients in the Western Pacific or in Asia. It's a viral infection transmitted by the mosquito, and as the name implies, it can cause things like encephalitis leading to seizures. The measles, mumps, rubella, so measles still prevalent in lots of places in Europe as well. And the yellow fever, again, another mosquito-transmitted illness, a viral infection that we associated with places in Africa and in South America. So in general, patients should be really up to date on all the routine vaccines that are recommended before they go. So a quick word on vaccines. Vaccines in general have a better efficacy when the CD4 count is above 200. However, if you're giving them when the CD4 count is less than 200, you may want to consider repeating the vaccine when their CD4 count rises appropriately, or even checking antibody titers to make sure they've had a complete response. Live vaccines really require special consideration because there are certain risks of developing active infection, and that's something that we're going to talk about a bit more as well. So I think this is a great summary. This is from the CDC. It's the most up-to-date adult immunization schedule for 2014, and I think it really puts into perspective well what vaccines are recommended and which vaccines we need to take care with. So you can see the flu vaccine, so influenza at the top there. So 1 dose of the intramuscular inactivated vaccine is recommended in patients. It should be given on a yearly basis. The active vaccine, which is the flu mist or the intranasal spray, is contraindicated at any CD4 count. And similarly, close contacts of HIV patients should also not get the live vaccine just because of the risk of shedding. Jumping down on the list there to human papillomavirus, you see female and males. So there's essentially 2 different types of HPV vaccines which exist, Gardasil and Cervarix, and females can get both, typically between the ages of 9 to 26. Males are only eligible for Gardasil, and this vaccine similarly can be given between the age of 9 and 26. Jumping further down there to the pneumococcal vaccine schedule, so you have pneumococcal 13-valent and pneumococcal polysaccharide. This is essentially the pneumonia shot, so it's recommended that patients actually get 2 doses below the age of 65, and they should be given about 5 years apart. For the pneumococcal 13-valent, it's also known as Prevnar, and that's recommended as a one-time dose. And it's important to know the timing that needs to be respected between these vaccines. So if you give a patient the pneumococcal polysaccharide, you should wait at least 1 year before giving the pneumococcal 13-valent. However, if you start with pneumococcal 13, you only need to wait 8 weeks before giving the polysaccharide, and that just has to do with the body's response time to certain antigens within the vaccine. Hepatitis A and hepatitis B, we spoke about those vaccine schedules. So hepatitis A is a 2-dose, so 2 doses that are given, one at 0 months and then one at 6 months. And for hepatitis B, it's 3 vaccines that will be given, one at month 0, one at month 1, and then again one at month 6. So the final note here is on live vaccines. So certain vaccines that are live will be contraindicated no matter what the CD4 count is. And this is something like flu mist, live typhoid vaccine, the smallpox vaccine, yellow fever, and the live oral polio vaccine. Certain things will be contraindicated if CD4 count is below 200, but can safely be given then if the CD4 count rises above 200. And those would include things like measles, varicella, and zoster. Okay, so these are vaccines that can be given, but special care needs to be given. And I'll just make a quick comment about the measles vaccine. Many of you may have heard in the news these days about these outbreaks across the states. So the measles vaccine, not only is important because it protects the children from infection, but it also serves to generate what we call a herd immunity. And that essentially provides a protective effect for the community. It keeps the virus out of the population so that patients that cannot get these vaccines, like these AIDS patients, can still be protected. And just to conclude, here are the resources that I used for this presentation. A lot of these sites, specifically the CDC, and again, aidsinfo.nih.gov, great fountain of information, very clear information in terms of specific recommendations for HIV patients and the management of their infections. So at this point, if anyone has any questions that I can answer right now.
Thank you so much, Dr. Muller. We so appreciate your presentation. If you do have questions, please type them into the speaker question box to the right side of the presentation, and we will see what we can do to get some answers. I will go ahead and start with the first question that was asked, which is, how do you prevent CMV retinitis?
As I mentioned before, there are certain opportunistic infections that we will prophylax for and certain ones that we don't. And some of the ones that we do not prophylax for would be CMV. So in terms, we treat CMV retinitis for sure, but we actually don't give specific medication to prevent CMV.
Okay, great. The next question is, what is the difference between zoster and varicella? If I'm saying that correctly, I apologize.
Sure. So basically, varicella zoster and zoster are similar. So varicella zoster is basically chicken pox. And we assume that once someone gets chicken pox, they won't get it again. However, they can have a reactivation of that virus, and that's when we get shingles or zoster. So basically, zoster and shingles are the same thing. It's when you get that dermatomal distribution, and it's basically a reactivation of that VZV virus.
Okay. And then the question is the shingles vaccine recommended?
So again, the shingles vaccine is recommended. It's typically given in patients over 60 years old and when their CD4 count is more than 200.
Another question is that some clients have asked about eating steaks that are not well done. Is that okay? And what about eating sushi? Is that safe?
Okay. With regard eating steak, they recommend actually that the meat should be cooked until no traces of pink remain. So no problems with eating steak, but patients should just definitely make sure that it's cooked all the way through. Regarding eating sushi, there's really no specific guideline or contraindication that I've come across, so I can't really comment on if that would be a contraindication. I think it could be risky, but nothing specifically preventing people from eating sushi.
Okay. You mentioned earlier in your slide set that if a patient has a primary OI with a CD4 below 200, you would give prophylaxis drugs. What if they have a CD4 above 200? Is there any consideration of giving a medication for people with a CD4 above 200?
Right. So basically we start prophylaxis when a patient has AIDS, and that typically starts with a CD4 count of below 200. So as long as the CD4 count is above 200, even if it's just a little bit above 200, they maybe warrant closer monitoring, but there's no indication to start prophylactic antibiotics as long as it's above 200.
You focused a lot on barrier protection for OIs. Is this information any different than how it should be used for primary or secondary infections?
Okay, I'm not too sure if exactly what the question is referring to, but whatever is recommended in terms of the barrier protections is something that it doesn't only apply to HIV patients, it should apply to all patients. Specifically, the condoms, the use of the condom is mainly to prevent sexual exposures that I had listed there before.
If a patient has a CD4 less than 200 and she or he is not on a prophylaxis medication, as a medical case manager, what do you suggest that I do? Should I contact? Should I have the person come back to the doctor? Talk about it?
So definitely, if the count is under 200, so they would need prophylaxis for PCP for sure, let's say, and then of course if it's below 50, they would need prophylaxis for PJP and for MAC. So it's definitely something that patients should be contacted about, and I think it's just a fair reason to have patients actually come back in to talk to their doctor, just because in this way not only are they getting their medication, but the doctor can properly explain exactly what the risks are and what they can do to potentially avoid them.
Okay. And another question is, are fermented foods allowed?
Fermented foods for the most part are allowed.
Well, thank you, Dr. Muller, so much.
Great. Thank you so much.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, FCAETC.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center, Project ECHO, provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.